Thank you, Thomas. It's a great pleasure to be here with you. We are here today with Kira Radinsky. Kira has a terrific story to tell us around the future of health. Without any further ado, I wanted to ask Kira if she could introduce herself, talk a little bit about her amazing background, and in a short way, how she ended up being here today.
Oh, thank you. Well, I'm always eager about how we can build artificial intelligence systems that are capable of predicting future events. While working on my PhD, I've built a system that's capable of taking whatever humanity wrote since 1851 till today and started building AI algorithms that read this information, identify patterns in history, and predict future events. While working in Microsoft research with collaboration with Eric Horvitz, we were working with the Gates Foundation to predict the first cholera outbreak in Cuba in 130 years. We then started collaborating with the UN to predict the Sudan riots in 2013. I then decided to build a company that was doing economic predictions, which was acquired by eBay, and I've been eBay chief scientist from Israel for a few years. I then joined as a visiting professor in machine learning and healthcare at the Technium, and this is where I met my two co-founders, Professor Moshe Shon, which is a very well-known person in healthcare. IPO'd a couple of companies, the larger one acquired for almost $2 billion by Medtronic, and with Jonathan Amir. We started building a company whose main focus is how can we reduce this amazing time that people are waiting inside emergency rooms? Because it's completely not clear how people can be waiting 3.6 hours on average in Israel, 3 hours in the United States. And do you know how much people are waiting in China? It can get to even 8 hours. Planes of sick people flying to emergency rooms are being deployed there. For this, we had access to hundreds of million different visits inside emergency rooms and primary care coming from Israel, from the Far East, and from the United States. And started building machine learning algorithms capable of reading the text inside of those medical summaries, extracting the answers to triage questions, and helping with the triage inside emergency rooms. The systems actually started outputting probability of referring to labs, probability of differential diagnosis, and of course triage, based on which different workflows could have been built inside hospitals. We then decided to go into primary care in order to reduce this 30 to 70% of the people inside emergency rooms that could have been treated from home or an urgent care clinic. So we extended our triaging to home. Since then, we've been working with 75% of the HMOs in Israel and triaging millions of people in the United States. Only in the last 3 months, we triaged approximately 2.4 million people. And then COVID happened. Approximately 4 months ago, we've been requested by the Israeli Ministry of Health to extend our clinical triage system, but this time to triage for COVID. Since then, all of the 8 million people in Israel have been completely monitored and triaged by a system. Behind the scenes, the system has been sending text messages from the medical providers to people, asking them a set of clinical triage questions. We built a machine learning algorithm capable of predicting from the symptoms what is the probability for COVID, aggregating this information and building epidemiological maps, predicting where COVID is right now, but also how it's going to spread. On a daily basis, we provide reports to the Vice President of the Ministry of the Health, telling them where the beginning of the spread is starting, which cities to quarantine, which ones to relieve, and where to send the different resource allocations.
That's pretty amazing, Kira. Thank you for sharing that terrific summary. I wanted to just probe on a couple items. You and I think, started somehow at the same place at Microsoft Research about 10, 12 years ago. And, although I had a very different role, I was taking, our cloud platform for health at the time called Health Vault to different markets, such as UK and Canada. Some of the issues that, I faced, and I think they still exist today, I wonder how you tackle them. One of them is, as you said, obviously, all the amazing algorithms and amazing work that you do and many startups do rely on data, right? And data is always a trouble, and in healthcare, adding to regulatory matters and privacy and so many other different things can be a headache. So could you talk a little bit about kind of some of those hurdles that you had to overcome and how you did it?
Mhm. So a lot of our systems are integrated inside the healthcare system. So we're not taking the data out in any form. We're part of an on-premise solution, enriching their data and having those classifiers joined externally to provide mutual predictions. But indeed, everything around privacy is of extreme importance for us. This is why we work on non-PHI data.
Okay, no, that sounds great. I wonder if you also could talk a little bit about, you've mentioned, doing a lot of work collaborating with the Ministry of Health in Israel and with many other both public and private sector organizations in different countries. Again, one of the other challenges I've always seen in solutions for health is that healthcare systems differ so much from country to country. Could you talk about, your vision, like how do you build this as a kind of a global company, taking in fact, the nuances of each healthcare system?
This is a wonderful question. Although the systems differ from country to country, eventually the human body is very similar. This is why we as a company focus on something very small but very useful, which is clinical triage. We know how to ask questions, how to reach triage, how to look at the history of the patient and how to reach this triage. Everything else, we're working with different types of integrators who are helping normalize the data in a form that our algorithm can reach those type of predictions. We provide different types of APIs and integration with already existing frameworks and systems. We do not build the workflows, we just build enablers for automated workflows inside healthcare systems.
Excellent. Thank you, Kira, for sharing. Another part of the story that I think you've summarized in a very concise way, but I wanted to just probe a little bit is the fact that one of the challenges of every startup is eventually you got to focus, and then you started this journey way before COVID-19 hit, right? And you had your resources lined up, your plans and everything else, and then COVID hits, and a lot of people still struggling with making adjustments, even simple things such as working remotely, for example. In your case, you kind of had much deeper changes in the company, I assume, than just the fact that we are sort of working remotely. Could you talk a little bit about how you pivoted or made adjustments to your plans and resource allocation throughout this period?
Definitely. So as a company, we've been focusing on clinical triage for the last few years. So the pivot was not such a big pivot, was just started triaging for COVID as well. What we needed to do is scale very quickly. From 6 million calls a year, we had to scale to monitoring, triaging 50 million people in India, Israel, and East United States. And all had to happen in less than a week. You had to get to a point where the integrations are not taking 3 weeks, 3 months, a year, as they used to be happening in healthcare system. They had to be up and running in a day. So all of the assets, technological assets we've been building for the last few years really were helpful, but we never anticipated to scale so quickly from amount of users.
Excellent. And again, you mentioned another critical piece, which is very close to my heart. My background was always in launching those kind of startup initiatives with partners worldwide. And you mentioned the word integration. I mean, a lot of health care constituencies work with either high-tech companies, such as Microsoft, Salesforce, long list of companies, as well as with system integrators, and this long list of them, I don't need to name them all here. How do you play in that ecosystem? What's your partner strategy or model?
We look at ourselves as enablers. In other words, we're focusing on something very small, clinical triage, and we usually integrate into existing systems. We partnered with Salesforce and Deloitte. Deloitte has been selling the system globally, specifically in Odisha and India. This was one of the first success stories. We don't see ourselves as somebody who's building the medical records. We don't see ourselves as somebody who's integrated with different sensors. We see ourselves as something who's taking all of those inputs and reaching a probability for triage or differential diagnosis. Therefore, larger integrators can take those and build different types of patient experiences with already different existing healthcare systems. Got it.
And again, you've clearly been a visionary throughout your career, and what you've been doing became even more relevant today, even though it was extremely relevant before. What do you think? I've honestly stopped doing some live events because everybody's trying to predict what will happen. And I humbly said, I've said what I know, and I know that I don't know so many things. But you're inside this system right now. I mean, what do you think are the changes that came that might remain in the longer term? I mean, what are your thoughts in terms of what's going to happen going forward?
Mm-hmm. We thought that digital health transformations is going to take 10 years. And then COVID happened and transformation started happening in months. Before that, people didn't think that it's possible to treat a patient remotely. Telemedicine was slowly growing. And now we get to a point where patients are just afraid to come to their medical providers. They want to finish entire medical flows from home and touch as little as possible with the care providers. Care providers are also worried. It's enough to have a single COVID patient and you have an entire department in a hospital that's going to be quarantined. So what started happening is that you need a scalable system to triage them remotely. And just having systems that are based on only humans triaging them did not scale during such a large pandemic, and we realized that. Till 2030, there's going to be 3.8 billion people without access to primary care. All the long lines we see inside emergency rooms are nothing compared to what's going to happen. And we see this happening right now in the pandemic. We're all in quarantine because the healthcare system cannot stand with the load that we're going to give it. So all of this digital triage system pretty much became something that it's not a nice to have, it's a must have. So I really believe we're going to see much more digital health enablers that are capable of creating this type of workflows.
I fully agree. I personally empathize a lot with that. I spent several years building what we call this digital transformation sales organization and really trying to drive the sense of urgency and show the outcomes of digital transformation. We did obviously very interesting thing, not just in health, but in financial services, many other industries. But yeah, it's maybe it's a bad joke, but the reality is, COVID-19 in a way came, and digital transformation became a lot more obvious and okay. So Kira, this is super interesting. I wonder if you could share with us some of the actual results that you've achieved so far. You talked a lot about remote monitoring. I was trying to drive telemedicine 10 years ago. We actually did some interesting projects in the US with New York Presbyterian and other clinics. But as you said, 10 years passed and COVID came and things accelerated dramatically. So could you talk a little bit about some of the results in terms of having, less invasive and controversial approaches? Could you just talk a little bit about the outcomes that you've observed so far?
So in general, our triage system has been reaching an AUC of 86 across different type of complaints, even reaching to 92 with ones like chest pains and headaches. Getting to a point where you have to triage a completely new disease was extremely challenging. We had to start with asking general triage questions. In Israel, for example, you could not do a COVID test unless you have fever and a cough. A system was one of the first one to identify that loss of taste and smell is highly correlative with the disease and very specific. And this helped change completely the triaging process for a test in all of Israel. Another last well-known one is that extreme fatigue when combined with dry cough is much more indicative than just fever. This is what the machine learning algorithm catches behind the scene about a personalized risk. This is only about COVID, but now think about this as what's the probability of this patient having MI? And what's the probability of this patient having, for example, UTI? So what started happening, we started building a system that interject different flows for the patients, when they're trying to schedule an appointment, when they're just trying to be triaged in a 911 call. All of those are going through a digital triage system. The digital triage system with AUC of 82, for example, for COVID, is being able to give indications what's the probability of them having COVID. But this is not enough. Even if you know if they have COVID, you do not know if they're going to deteriorate or not. We started building models that try to predict what's the probability if somebody has COVID, well, whether they will deteriorate. The way we were building this, we had access to 20 billion claim data. We started looking at patients that deteriorate to ARDS. 30% of the patients, for example, in Italy out of COVID died from ARDS. We reached with an AUC of 97, very well predictions, giving the patient's background alone without a single question, whether they will deteriorate or not. Using this prediction, the system has provided an ability to navigate those patients after their first triage process. Patients with high probability for deteriorations are being directed immediately to emergency departments in hospitals. Patients with low ones are being sent to COVID hotels or being directed to stay at home until they feel more severe symptoms. In April 4th, we allowed ones to publish our predictions on an aggregated level, on an epidemiological level. We published 3 names of cities, Migdal Emek, Tiberia. Those, after a couple of days, the government has sent COVID tests, validated our predictions, quarantined those cities, and since then, the system is being used for any type of predictions around which cities to quarantine or not. Based on these predictions, they decide whether to send COVID tests or not. And today, this is the only digital solution that Israel employs. At the beginning, Israel was also deploying systems around tracking via GPS locations, whether there have been an exposure with a COVID patient, but those have privacy issues that were discontinued. Today, what the system is providing is not only the probability of a symptomatic load in a certain city, but also analyzing patients who have done private COVID tests and comparing this to information that the Minister of Health has. We find large gaps in, for example, in the southern city in Israel, that the Minister of Health had no indications that COVID, but based on a system, we identified high symptomatic load and a lot of private COVID tests self-reported. Based on this information, they started doing COVID tests by the Minister of Health, validated the results, and quarantined the city. All of them allowed an SLA of a day. This is of extreme importance now during the second wave, because when we start to identify growing symptomatic load, like we have identified in South Tel Aviv with the immigration population, it allowed to close those areas in a single day, preventing the widespread of the disease.
That's fascinating, Kira, and that gets me to another question, which is slightly controversial, but I'll try and ask in a PC manner. I grew up in Brazil in a house of physicians, and following the news situation there, we talked a little bit about bringing diagnostic robotics to Brazil, but I think it definitely would be a great thing, and I hope we do that. But if you look across the world, several European countries, Asian countries, US, you name it, there's lots and lots of challenges, and unfortunately, the scientific knowledge somehow conflicts a little bit with political views, and there's a big mess in many parts of the world, not to name any few specific ones. The last two questions to you. First of all, I think what you've done is amazing, and the sky is the limit. So what's next for diagnostic robotics, and what keeps you up at night today? And I hope you're sleeping well.
What doesn't? We need to get ready for the next pandemic. And the next pandemic doesn't have to be a disease. It's all about the aging of the population. We really need to understand that everything we have right now is a transition period before the healthcare system might collapse. And if we don't digitalize a lot of these processes, there is already a shortage of around 90,000 primary care physicians only in the United States. It's not scalable to build more doctors. We have to automate a lot of these processes. How can a primary care physician actually take care of 2,000 patients? They cannot go deep for each one of them. We have to make systems that enhance them, that automate them. We've seen this happening a lot in banking and advertising, but healthcare is approximately the last one that is experiencing all of those enhancements in digital support systems. I really think that this pandemic has changed the way we view healthcare and understand that something as simple as a small virus that starts to be contaminating can completely crash not only healthcare. And if healthcare crashes, economy crashes. All of this is intangible, and if we do not actually invest in those now, it's going to be much worse in the future. This is why I'm coming actually with a very optimistic view about the fact that, well, we've been all shaken by everything that happened right now, and let's leverage this to make healthcare better, cheaper, and more democratic as well.
Fully agree with you, Kira. I really want to thank you, and I had lots and lots more questions, but would need a lot more time. So I wonder if you want to make any closing remarks, any advice for you have over 1,000 health professionals and people in the digital transformation field listening now. Any additional thoughts, experiences, or advice you want to share?
So today we're actually focused on two types of triages. One of them is the proactive triage. In other words, identifying all of the history of the patients who will deteriorate. What we learned is that it's not enough to know who will deteriorate. Not all of them can be prevented. You really have to focus on the ones that can be prevented. But not only that, you have to identify the interventions. A lot of our work today around artificial intelligence is around the causal inference. In other words, which intervention can actually cause a preventive measurement for those patients. Don't focus on everybody, focus on the ones that you can actually help with. The second one is when a patient has already a problem, start building automated processes of triaging. Know which ones you have to treat immediately, which ones you can treat in a few days from now. Primary care is very similar to urgent care. In other words, we have to think about this. We have to think about triaging in primary care as well, especially with the growing number of population that we have right now. And automate as much as possible. Don't write the medical summaries, make a system write it for you. Don't know the triaging, build the protocol triaging before seeing you. Get the patients ready with doing lab tests before they meet you. Get the patient intake automated so you can actually do the patient-facing time, the physical examination, instead of wasting or including the other times that you are not as efficient as a system, which is completely automated.
That's great. Kira, I want to really to thank you, congratulate you for all you've done and what you still continue to do for society in general. I thoroughly believe that you know, what needs to be done now should have been done 10 years ago, but better late than never. And I just wanted to express my gratitude and admiration for all the work you've been doing. And thanks for sharing with us such great content today.
Thank you so much. Have a great day.
You too, Kira.